Hi, I'm Dr. Robert Bransfield, an American psychiatrist from New Jersey, and thank you for inviting me to talk to the Welsh Parliament today. I'm sorry I can't be here. I have Welsh background dating back to Owain Gruffudd, who was King of Gwynedd in the 12th century, and his descendant, Dr. Thomas Wynne, who was William Penn's personal physician and a politician who helped establish Pennsylvania in the 17th century. I specialize in treating psychiatric patients who are treatment resistant, and this has resulted in my working with thousands of patients with Lyme and associated diseases over the past 30 years. In combining clinical experience with a broad spectrum of research, it becomes increasingly clear that injury from infections, including particularly tick-borne infections, cause a significant number of chronic conditions that impair, disable, and kill a large number of people. This is a major paradigm shift in medicine and gives us an opportunity to more effectively prevent and treat many conditions that were previously had much less treatment options. The Lyme disease spirochete has been found in ticks in amber that was 15 million years old. It's the most complex bacteria known and has great adaptive capability. We cannot apply the rules for other bacteria to Lyme disease. In addition, there are many other tick-borne co-infections and an activation of other latent opportunistic infections which cause complex interactive infections. The problem I have seen and written about in peer-reviewed medical journals include persistence of infection, addressing how Lyme bacteria causes immune and metabolic effects that result in a spectrum of neuropsychiatric symptoms that may include developmental disorders, autism, schizoaffective disorders, bipolar disorders, depression, anxiety disorders, eating disorders, sleep disorders, addictive disorders, cognitive impairments, dementia, seizures, suicide, violence, and other impairments. Common general medical symptoms include fatigue, musculoskeletal pain, headaches, nerve pain, as well as gastrointestinal, genitourinary, and cardiac symptoms. Many Lyme patients are given other diagnoses and are told their impairments cannot be cured and can only be managed. These diagnoses include multiple sclerosis, motor neuron disease, myalgic encephalomyelitis, chronic fatigue syndrome, bodily distress syndrome, and a number of mental illnesses. And these diagnostic errors obstruct access to more effective treatment. Many fatalities, both recognized and unrecognized, may be associated with suicides, drug overdoses, homicides, accidents from cognitive impairments, and multiple neurological and general medical impairments. Some of the individuals who started their research on tick-borne disease in the 1970s made major conceptual errors, looking at this problem from a very narrow and limited perspective. And these errors have been perpetuated in an extremely narrow disease definition. Rather than moving forward, many of these errors have been dogmatically defended in spite of overwhelming clinical and scientific evidence to the contrary. We are learning ecological disruption can foster the proliferation of ticks, and the parasites which they transfer from many wild animals into humans can cause complex interactive infections, and these pathogens can survive in us by evading and disabling the immune system and causing multiple pathology in the process. The chronic immune effects from these infections can then impair physical, cognitive, emotional functioning and can cause general medical illnesses, mental illnesses, and behavioral problems. To make forward progress with this epidemic, we created the International Lyme and Associated Diseases Society, ILADS, and we have meetings in North America and Europe. We wrote clinical guidelines recognizing the significance of clinical judgment in 2003 and again in 2014, following the scientifically sound GRADE approach, which is the standard for healthcare guidelines. We are dealing here with a very complex problem. There are more facets to this epidemic than there are in the crown jewels, and no one is an expert in all the facets of this epidemic. Improved awareness of this association provides new opportunities for prevention and treatment that were previously overlooked. This is not just a problem for ecologists, entomologists, veterinarians, microbiologists, infectious disease doctors, immunologists, psychoimmunologists, psychiatrists, general medical physicians, patients, or governmental policymakers. It is a problem for all of us, and we need cooperative effort from all of us. Forward progress in the understanding of Lyme and associated diseases and access to adequate care have been very slow for decades. It has been stalled by silo mentality, a failure of creativity, adherence to flawed guidelines, and special interest. This epidemic gives us a choice and an opportunity. One choice is for a group of us who normally don't work together to be a team to solve a very complex problem that harms humanity and to help advance science and medicine and improve the quality of life for many. The other choice is to maintain the status quo and blindly follow outdated beliefs. As government officials, you are in a unique position to help science and medicine move forward by establishing policies that improve prevention, clinically relevant research, access to effective care, and accurate education of health care workers and the public. Full consensus and supporting evidence in science are rare, and competing views are the rule rather than the exception. There is a major controversy surrounding Lyme disease. One view is the narrow definition that conceptualizes Lyme as having reliable immune-based testing. It is a laboratory rather than a clinical diagnosis. The symptoms are not very severe and can be called just the aches and pains of daily living. Chronic infections do not exist. Co-infections are mostly insignificant and is easily treated with short courses of antibiotics. The broader definition recognizes the commonly used immune-based tests are highly flawed. The overall clinical assessment is critical in making the diagnosis. There is a broad spectrum of symptoms that can be quite severe. Chronic Lyme, it does exist. It is complicated by multiple co-infections, and some patients require extensive courses of antibiotic treatment. The total clinical exam is a cornerstone in medicine. The diagnosis is not just based on a flawed lab test, and every patient's treatment must be individualized. This is the approach in treating every other disease. Why should Lyme disease be an exception to a concept in medicine that has existed since Hippocrates? Based upon several studies, there is a very broad spectrum of symptoms that can be quite severe. A U.S. National Institute of Health study found that patients had high level of functional disability compared to what you would see with congestive heart failure and pain comparable to what you might expect coming out of surgery and fatigue comparable to patients with multiple sclerosis. The most disabling symptoms are fatigue, pain, cognitive impairments, psychiatric symptoms, and sleep disorders. Unfortunately, many who write infectious disease guidelines have very little competency in properly assessing these symptoms. In regard to persistent infections, on the internet I compiled 700 peer-reviewed articles demonstrating proof that persistent infection frequently occurs. This is well demonstrated with animal studies, autopsy, case reports, and review articles. A U.S. CDC study found the majority of Lyme disease patients are being treated with antibiotics for longer periods of time than are advocated by the IDSA guidelines, and only 39% of Lyme patients are being treated with short courses of antibiotics of 4 weeks or less. In addition, a recent study of 3,900 patients has proven there's a group of chronic Lyme patients that clearly benefit from longer courses of antibiotic treatment. Since there are conflicting opinions, research, and guidelines surrounding tick-borne disease, none are authoritative. The standard assessment in medicine is to perform an adequate exam that is relevant to the patient's complaints. We treat patients, not diseases. Laboratory findings have different degrees of reliability and should never be the sole diagnostic criteria, and Lyme disease should be no exception to this. Rarely is a diagnosis black and white. Individualized assessment and individualized treatment are always necessary. Evidence-based medicine is a combination of the best evidence available, clinical judgment, and patient preferences, all of which have limitations. Since the evidence surrounding Lyme and tick-borne disease is conflicting and unsettled, it is dangerous to impose rigid third-party diagnostic and treatment criteria. The standard of care is established by physicians who have the long-term responsibility for treating a disease, not by physicians who deny the significance of a disease. There is a very major distinction between standards of care and guidelines. Unlike the standard of care, guidelines are only suggestions for assistance with clinical decision-making. Unfortunately, a number of Lyme disease guidelines are established by epidemiologists, bench scientists, and researchers with an inadequate understanding of all the facets of the disease and without input from clinicians who have the long-term responsibility for treating these patients. Studies have shown the most significant and disabling symptoms from tick-borne diseases are fatigue, sleep impairments, pain, depression, cognitive impairments, anxiety, and irritability. Many who view themselves as Lyme disease experts and write guidelines which may be imposed upon others have no or very little experience regarding these symptoms. When what begins as an infectious disease and is inadequately diagnosed or treated can later become a psychiatric illness. The American Psychiatric Association assessment guidelines recognize the need to consider Lyme disease in the etiology of psychiatric illness. And the ILADS and German guidelines recognize longer courses of antibiotic treatment are needed for some patients. The IDSA guidelines include a disclaimer recognizing the need for individualized clinical judgment. These outdated guidelines from 2006 have had multiple criticisms and challenges since the day they were published. They are highly biased, lack objectivity, and a large percent of the reference in the guidelines consist of the authors quoting their own work. Lyme and associated tick-borne diseases are treated by physicians from all specialties, and no medical specialty can call themselves the sole authority. Most late-stage disease is treated by physicians who recognize the broader definition of Lyme and are more inclined to follow the ILADS approach. Since the standard of care is determined by physicians who actually treat a given disease, the standard of care in late-stage Lyme disease most closely approximates the approach used by physicians who use the broader definition and the ILADS guidelines. The IDSA guidelines and other guidelines which copy them fail to adequately address the most significant late-stage symptoms, which include fatigue, cognitive impairments, psychiatric manifestations, and pain. If an inadequate clinical exam is performed, it can result in erroneously viewing the symptoms as having a psychiatric origin, and the patient is improperly labeled as having medically unexplained symptoms or bodily distress syndrome. Some quotes relevant to standards from the 2018 Tick-Borne Disease Working Group report submitted to the U.S. Congress include, thousands of articles show the association between infections and neuropsychiatric manifestation of illness. At least 400 articles support the association between tick-borne disease and neuropsychiatric disorders, which include but are not limited to depression, anxiety, bipolar disorder, cognitive impairments, and psychosis. When more than one set of guidelines exists, the question then becomes, who decides the appropriate course of treatment for the patient? Under the medical ethics principle of autonomy, the treatment decision belongs to the patient in consultation with his or her provider. As policyholders, you can play a critical role here to move forward science and medicine by developing policies that support individualized treatment, accurate physician education, clinically relevant research, and the recognition of the dangers associated with improper reliance upon flawed testing, inadequate diagnosis, inadequate treatment, and unfounded confidence in the deficient NICE guidelines. Please seize this opportunity to help us, to help our family members, your constituents, and our patients. Thank you.